Good evening, sir.
Very good evening.
Good evening to the learned faculties and all the participants and panelists for this 74th issue of our Enoch DigiConnect webinar series. Before we start this webinar, let me welcome all the participants and the panelists for this webinar. And as you all know that this month is the Breast Cancer Awareness Month. So we are all dedicatedly deliberating on the different aspects of screening and diagnosis of the breast cancer so that this particular breast cancer can be controlled in India and across the world. So may I request our President, Dr. Jain sir, to give the welcome address.
Good evening, friends. I welcome you all to this 74th issue of our webinar series, which we are organizing for last almost 1 year and 9 months now, when the COVID started and the physical seminars were stopped. So we converted into webinars. Today we have got two esteemed speakers with us, Dr. Parveen Jain, medical oncologist from Akash Hospital, and our own Dr. Rajiv Jain, Vice President of our association. Dr. Parveen Jain shall be speaking on the latest trends in the diagnosis and screening of breast cancer. And as Dr. Sandeep has already mentioned, this month we are celebrating this Breast Cancer Awareness Month. And unfortunately, the breast cancer has become now #1 killer in the country. I think, is it so, Dr. Parveen Jain?
Yeah, it's absolutely true. In females, it has become the #1 killer.
#1. So with these, this situation in the country, I think the topic is very, very apt. And I welcome both the esteemed speakers as well as I welcome all the participants. Thank you.
Thank you, President, sir. So the topic for today are both topics are very apt, and one is the breast cancer, which is where we are deliberating during this Breast Cancer Awareness Month. And it is a topic of interest to every industrial physician, how to prevent breast cancer amongst the workforce and amongst the population. And the second topic is by our Senior Vice President, Dr. Rajiv Jain, that is COVID rapid update, because still the COVID pandemic is still evolving and still the numbers are fluctuating, and our vaccination coverage is also not 100%. So we need to be very careful during these circumstances, and he will guide us how to take care and what are the new developments during this evolution of the COVID pandemic. Now, regarding this Breast Cancer Awareness Month, this month is observed by WHO and the organization and individuals around the world to raise awareness about the breast cancer. And so aptly, we have from AUSD, we have decided to deliberate on this particular issue during our weekly webinars for the whole month. And Dr. Parveen Jain sir, you are, I think, second or third speaker to deliberate on this particular topic. And this, as rightly said, amongst female, the breast cancer is the most prominent. It is about 12% of the cancers, and 11% are the lung cancers, 7% in males are the prostate cancers, and 10% are the colorectal cancers. So breast cancer is the most commonly diagnosed cancer globally, and survival also after diagnosis, it exceeds 80% in most high-income countries as compared to 66% in India and just 40% in South Africa. So the countries, underprivileged countries where healthcare infrastructure for diagnosis and treatment is not up to mark, there the survival is low. So it is important. Why? Because it may lead to social disruption. It leads to impoverishment, family instability, orphan children, and decline in economic growth. So breast cancer is very important for every one of us. If there is any doubt in the mind of any female member of any family, then the whole family is disturbed. And in that case, we need the guidance of the super specialists who are day in, day out dealing with this particular problem. So the three pillars of breast cancer will focus on health promotion, timely diagnosis, and comprehensive treatment and the supportive care. So Dr. Parveen Saab, we would like to hear the latest developments and the guidelines from you to we all industrial physicians. For your introduction, this society, our association is the Association of Industrial Doctors, Public Health Physicians, and Occupational Health Physicians across India. And we are more than 3,000 across India, and in Delhi we are more than 250, and most of us, we are medical heads of our respective organizations, whether it is public sector undertakings, Indian Railways, or private or corporate hospitals, so corporate organizations. So we, as the President sir has already told, for last 1.5 years, in these new norms, we have been discussing all these new issues, how to tackle with the COVID pandemic, and in between, how to enhance our knowledge through this COVID, through this weekly webinars. So yours is the 74th issue, and all our these topics, they are available. Sessions recordings are available on the YouTube channel in our DigiConnect webinar, and this is being live telecast also on the YouTube. So for introduction to all the members who have joined in and who are all live on the YouTube, this particular session is on latest advances in screening and diagnosis of breast cancer. And this is being taken by Dr. Parveen Jain, who is Senior Consultant and Head of the Department of Medical Oncology, Akash Healthcare Super Specialty Hospital, New Delhi. And Dr. Parveen Jain is working in the field of medical oncology since last 7 years, and he has a vast experience in the management of both hematological and non-hematological malignancies. And he has completed his MBBS from KMC Mangalore, and he cleared his European Certified Medical Oncologist exam conducted by ESMO in 2016. And he has been having a keen interest in conducting clinical research and participated as co-investigator in various phase 2, phase 3, and phase 4 trials. So he has done many oral and poster presentation in national conference and international conferences also. And with this background, sir, I think you are the most apt person to guide us regarding breast cancer. So, Dr. Parveen Jain, sir, your floor is yours. You can start your deliberations.
Thanks a lot, Dr. Sharma. So it was very nice hearing your introduction and regarding the topic also, because it's a most discussed topic in October month. October month, it is celebrated as a National Breast Cancer Awareness Month, and I think this is one cancer where, one second, let me share the screen. So this is one cancer where appropriate knowledge about the cancer in all type of physicians and in patients also, so it can lead to a lot of reduction in the mortality and morbidity of this particular cancer. So my screen is visible, I hope.
Yeah, yes.
Okay, one second. So today we will discuss regarding the breast cancer. So it's going to be a short presentation, and after that probably we can focus more on questions and answers regarding the latest advances regarding the treatment. If anybody is having any clinical scenarios, so we can take those clinical scenario as well. So this is the place where I'm working presently. So previously I was there in Rajiv Gandhi Cancer Institute. Recently in August 2021, I have joined this hospital, Akash Healthcare, in Sector 3, Dwarka. So we are going to discuss the breast cancer. So 2 or 3 slides of basics of breast cancer, basics of breast, then what are the factors for breast cancer, then what are the clinical features, everything we are going to discuss in very, very brief. So it's screening, So what are the modalities which we can use for screening? So what are the diagnostic modality? How we usually proceed whenever a suspected case of breast cancer is presented to us? And finally, brief about the treatment and latest advances about the treatment. So, so this is a normal human breast. So we can see over here that this is the chest wall, and everything in front of the chest wall, it constitutes the breast. Breast has got the mammary glands and the fibroadipose tissue. So fibroadipose tissue, it supports the mammary gland, and these mammary gland, they constitutes of lobes, the violet structure. So these are the lobes, and in between these lobes there are the ducts that carry the milk from the lobes to the nipple. So the function of lobes, they are to formulate milk, and function of the ducts, that is to carry the milk from the lobes to the nipple. So these mammary gland, usually they are very well formed in a human females, but sometimes such kind of like breast tissue, mammary tissue, they also develop in males also. So if we talk about the physiology and functionality of breast, so these lobes, the mammary gland, they developed under the stimulus of estrogen hormones, and then they start secreting milk. And during the reproductive age group and after pregnancy, these milks are secreted under the influence of prolactin, and the lobes, they form the milk, and duct, they carry the milk from lobes to the nipple. So usually breast cancer, it develops in the mammary gland, maybe in the lobes or in the duct. So whenever the cancer developed from the lobe, so that is called lobular carcinoma. And whenever the cancer develops in the cells which are lining the duct, so it is called ductal carcinoma. So these are broadly two types of cancer which we encounter. Both are type of adenocarcinoma. So this is the physiology. So these are the four key hormones which plays part in the development of breast and secretion of milk. So estrogen, it is mainly secreted by the ovaries, and it promotes development and maintenance of breast tissue. Progesterone prepares the mammary gland for milk secretion. Then prolactin, it initiates and maintain mammary gland production throughout the lactation. And oxytocin is something which stimulates ejection of milk from the mammary gland. So it happens when a baby sucks on the nipple. So in 1 second, please. Yeah. So what is the clinical relation of all these? Why we should know about these hormones? Because what happens is that whenever there is a hyperestrogenic state, so there is increased chance of developing breast cancer. So whenever so estrogen is something which we have to see whenever a female is getting a breast cancer, because 70% of these cancers, they are hormone receptor positive, and in one way or another estrogen plays some part in the development of cancer. So what are all the scenarios? So we will discuss in the risk factor, so which are the state where estrogen is there in excess, and which can lead to increased chances of development of breast cancer. So regarding the risk factor, the first and foremost risk factor is the gender. So we know that breast cancer, most of the times it develops in females, but rarely it can develop in males also. And so the relative risk of development of breast cancer in female as to male is almost 100 times. If we see the age, so the risk of development of breast cancer, it increases as the age increases. And it is seen then that after the age of 40 to 45 years, this risk of breast cancer, it increases proportionally to the age. And that is why the screening, most of the screening guidelines are in favor of doing a screening post 40 years, because the risk of developing breast cancer is more after this particular age group. If we see genetics, so almost 12% or of breast cancer, they are related to the genetics. And most of these patients, they develop some inherited mutation in BRCA1 and BRCA2 gene of family. Apart from BRCA1 and 2, so there is something called CDH or Lynch syndrome, where again the breast cancer risk increases. If we see the family history, so genetics is something that where we are able to find out the genetic aberration. Family history is any person who has got a drug, first degree relative or second degree relative with breast cancer. So they have got a family history of breast cancer, and it leads to increase in risk of developing breast cancer in a particular individual. If we see personal history means that if a female who was diagnosed with breast cancer, completely treated, surgery, chemo, radiotherapy, everything finished, but there is almost 3 to 4 fold increase in development of another breast cancer in this particular female. So this is called personal history. Then hormone exposure and profile. So this was the factor which we were discussing. So anything which leads to increased exposure of a female breast to estrogen, that can increase the risk of development of breast cancer, like early menarche, late menopause. So both of these, so there are a lot of estrogenic exposure to the breast. So that is why these female with early menarche, late menopause, nulliparous females, so they have increased risk of development of breast cancer. Oral contraceptive pills again and hormone replacement therapy, both. So both, they have increased risk of development of breast cancer. If we see only estrogen pills, so they do not increase the risk of breast cancer. But whenever a combined hormone replacement therapy is given with estrogen plus progesterone, so it definitely increases the risk of breast cancer. So similar to that, so the other factor which leads to reduce exposure to estrogen, they decrease the risk of development of breast cancer, like oophorectomy before menopause, pregnancy before the age of 30 years, then breastfeeding. All of these are the factors which lead to decrease in the estrogen exposure. Then there are other environmental factors like obesity. Obesity particularly is a very important risk factor in postmenopausal female. In premenopausal female, it has not been shown to have an increased risk of breast cancer, but in postmenopausal, definitely obesity is a very important risk factor. And similar is the alcohol intake. In premenopausal ladies, alcohol intake doesn't lead to significant increase in breast cancer, but in postmenopausal, yes. Then receival of ionizing radiation, like in those patients who had lymphoma in the early age group where they were treated with radiotherapy, so they are at increased risk of developing breast cancer. So this is the reason that from the early Hodgkin lymphomas, initially the therapy was combined therapy with chemotherapy and radiotherapy. Now the protocols containing the radiotherapy, those are already started to go into the past. And if we see lifestyle modification like reducing the weight and regular exercise, they reduces the risk of development of breast cancer. So there are a lot of factors other than this also which are non-modifiable. So but these are the most important factor which can lead to development of breast cancer. If we see the clinical features, so the clinical feature depends on the loco-regional, whether the tumor is loco-regional, that means stage 1 to stage 3, or whether the patient is having any distant metastasis. Most of the times these female, they feel some sort of lump which is usually hard and painless. So whenever a female notice a lump, so these are the main this is the main clinical feature. Then there could be nipple discharge, there could be some skin changes like rash on the skin, eczema on the skin, inflammatory changes on the skin, ulceration on the skin. Then apart from this, there could be edema of the skin, like just like orange peel, which we call PUD orange. So these are the skin changes in CA breast. Apart from these, there could be some nipple discharge, asymmetry of the breast. So one breast appears bigger than the other breast. there is some dimpling of the skin. So these are some of the common sign and symptom which most of the female they encountered and they report to the doctor. If we see about the clinical feature of advanced breast disease, it depends on what sort of metastasis these patients are having. Whenever the patient is having bony metastasis, it could lead to pain. Sometimes it could lead to instability of gait. If patient is having liver metastasis, it could lead to nausea, vomiting, anorexia, pain in abdomen, jaundice. So the type of feature, it depends on, so what is the area of metastasis. And if we see particularly what type of tumor metastasized to what type of sites, so usually the hormone receptor positive tumor, they metastasize to bone. They have very less visceral metastasis. If we see about the HER2 positive tumor or hormone receptor negative tumor, they have propensity to go into the visceral organ and they can lead to brain metastasis, lung metastasis, and liver metastasis. So these are very important and pertinent points, that if a patient is having hormone receptor positive, so it is always initially they metastasize to bone, and whenever there is hormone receptor negative or HER2 positive, so they usually metastasize to viscera. So coming to our topic of focus today, so that is screening. So for the part of screening, usually it is very important to risk classify an individual. So most of the females, they are categorized into average risk. So these are those females who do not have any sort of major risk factor. So what are the major risk factors? The major risk factor which we discussed in the risk factor, those are mainly the major risk factor. Any female who doesn't have any of these risk factor, they have less than 15% risk of development of breast cancer in lifetime. So I forgot to tell that almost 12.5% of females, they will develop breast cancer during their lifetime. So 1 in 8 female will develop breast cancer. So the risk is that high. But if we see, so this average risk category is the same category that any female without any risk factor, so whatever risk she is having, that is called average risk. If it is more than that, so those are the moderate risk and high risk categories. So high risk category is those with genetic mutations which can lead to development of breast cancer, like BRCA1 or 2, or a person or a relative with BRCA1 or 2 gene mutation. So these individual with a relative of such kind also have got high risk of development of breast cancer. And third is what we discussed, that history of chest wall radiotherapy for some other cancer between age of 10 to 30 years of age. So these are the three high risk categories. And apart from average risk and high risk, whatever comes, so that is there in the moderate risk. So but we are going to discuss the screening guidelines mainly for the average risk and for the high risk, because these are the two most commonly encountered categories for us. So what are the screening modalities? So first of all, what is cancer screening? These are the test and examination that provides evidence of disease in asymptomatic individuals, and this leads to detection of cancer in a very early stage, and the chances of cure of cancer is pretty high in screen detected cancer as compared to those who were detected to have cancer because of the clinical symptoms. And the goal of cancer screening is to find cancer before they can cause symptoms. So these patients are usually asymptomatic. So what are the modalities which are used for cancer screening, breast cancer screening? First is breast self-awareness or self-examination. So every female should be aware of her breast. So once in a while, she should stand in front of mirror and they should do self-examination of breast. And there are many guides which direct a female for step-by-step approach to breast self-examination. And the picture shown on the right, so initially female has to stand in front of mirror and they have to palpate the breast in a circular motion in clockwise direction. After that, they have to palpate the lymph node in the axilla. And third is to check for the discharge. Apart from these examination, so female should stand in front of mirror and she should raise her hand and she should see any sort of asymmetry in the breast. So if there is asymmetry, it points towards some pathology in the breast, which could be cancer also. Apart from this, every female should undergo clinical breast examination by a healthcare professional. So the difference between breast self-examination and clinical breast examination is that clinical breast examination is performed by a healthcare professional, and it has got a slightly higher sensitivity and specificity as compared to breast self-examination. If we see the screening mammography, it is a low dose X-ray imaging of breast using special instrumentation. Usually, the breasts are compressed between these two plates, and there are different views. But in screening mammography, usually there are two views which are taken. One is the MLO and one is the craniocaudal view. So with these views, usually the radiologists, they see regarding the any sort of masses or calcification, or if there is any speculated lesion which is seen on these particular x-rays. So this is called screening mammography. Many a times in younger individual, these screening mammography, x-ray mammography, they have to be supplemented with ultrasound, and sometimes based on the report of these two modalities, patient might require MR mammography also to further evaluate. So usually in mammography, be it digital mammography or ultrasound mammography or MR mammography, so there is a reporting system called BIRADS, which is followed throughout the world. It is a uniform system which was developed to remove the heterogeneity in the reporting of breast imaging. So this BIRAD system is into place worldwide. So there are 6 categories: breast BIRAD 1 to BIRAD 6, and usually BIRAD 1 is normal breast with no evidence of any lesion in the breast. BIRAD 2 is when there are lesion, but they are absolutely benign, and the chances of development, chances of cancer in those lesion is almost almost nil. So BIRADS 3, when the chances of malignancy in the lesion noticed in the imaging is less than 2%. BIRADS 4 is 2 to 90%. So as the category of BIRADS goes up, the chances of detecting cancer in this particular imaging is high. So these are the guidelines for average risk women. So there are various authorities which suggest different guidelines. Most of the places, either American Cancer Society guidelines they are followed, or American Society of Radiology guidelines are followed. So these are the ACS guideline for average risk women, and they suggest that breast self examination, it is an optional methodology. It is not recommended in the 30s, and women in 20s and 30s, they should have a clinical breast examination every 3 years, and after age of 40 years they should get a mammogram every year, and they should continue to do so as long as they are in good health. So so breast self examination, it is not a modality. Clinical breast examination should be performed every 3 years, and annual mammogram should be performed in those more than 40 years. So for high risk women, so these are the guidelines that an annual screening mammogram and bilateral breast MRI both are required for these women, and so between 10 year and 30 year, and post 30 year only one modality, either mammogram or screening mammogram or MRI, they are good enough. So now coming to another topic of today, that there is a breast cancer diagnosis. Usually whenever a female So breast cancer could be detected because of the screening or because of the patient reporting the symptoms of breast cancer. So whenever a patient come to us, so the initial investigation is mammography or ultrasound mammography, where we are able to find out the small lesions or some calcification. So we tend to get the report according to the BIRADS category. Whenever we notice a BIRAD 4 or higher lesion, so we go ahead and do the biopsy of the lesion. So MR mammography, again, same sort of scenario. So there are many advantages of each of these, and there are certain limitations also. Like mammogram, it is very easily available, easy, cheap, and it can be reproduced. So if we see about the ultrasound, it is mainly useful in those with dense breast. So usually when we see females less than 40 years of age, so the mammary tissue, it is very dense. So that is why mammography, they are not able to pick up small lesion which hides beneath the dense breast tissue. So there the ultrasound carries its role, and these are the patient where ultrasound should be done, and MRI should be done whenever we are not able to categorize lesion in with the help of mammography and ultrasound. So there is the role of MRI. But MRI, it leads to more false positive result, more over treatment. So that is why MRI is not a scan which is routinely done for diagnosis. So CT, usually it is done, CT and PET CT, usually they are done to stage the disease, whether the patient is having any sort of metastasis to viscera, or if there are any axillary lymph nodal metastasis or lung metastasis. Bone scan particularly is sometimes useful for detecting bone metastasis. But practically, if you ask me, so in Delhi, so PET scan. So these are very easily available right now. And in fact, if we discuss regarding throughout the world, so PET CT is something which is very easily available in India and in particularly Delhi. And the cost of PET CT scan also is very less as compared to computed tomography or CT scan of the chest and abdomen. So these days, PET scan, they are being done at any price tag of 8,000 to 22, 23,000, and they have got a very high sensitivity to find out the metastatic disease. So this is biopsy. Biopsy is definitely required in all cancers, and particularly all breast cancer, so that we are able to sorry. So breast biopsy is required to categorize the cancer into one of the molecular category. And the type of biopsy, it depends on, so what is the size of the tumor, what is the location of the tumor, and whether we are going ahead with the neoadjuvant therapy or not. So these are the type of biopsies. So first is the fine needle aspiration biopsy, where there is a thin needle which is inserted in the tumor, and some material is aspirated. So we are not taking any core of the tumor in this particular type. But these are definitely very useful in those scenarios, in the recurrent scenario where there is bony site, or when there are deep lesions, where and the small lesion where biopsy is definitely not when the tumor, they are not amenable to core needle biopsy. Core needle biopsy, these are the most often used type of biopsies. So one is stereotactic, other is the vacuum assisted. So these are again the advances which have come up in the in taking the biopsy of the breast. So stereotactic is when it is a guided biopsy where the tumor is localized, and the tumor is localized and it is hit by the machine, and they are able to take the biopsy from the guided region. Vacuum assisted biopsy, it is a very important type of biopsy in those lesion which grows along the ducts, and sometimes we are not able to get the representative sample with a stereotactic biopsy or guided core needle biopsy. So their vacuum assisted biopsy or VAB, vacuum assisted breast biopsy, these are very, very helpful, and sometimes they are able to take a good chunk of tissue for molecular testing also. So if we see the surgical or open biopsy, these are very, very less frequently done these days. And usually these type of biopsies are done when the tumor is less than 2 centimeter and the tumor is excised in toto. And finally, the decision is to be made after that, that whether the patient has to undergo lymph node dissection or not. So whenever we acquire the biopsy tissue, there are certain set of markers which are done on the biopsy initially to prove whether it is a breast cancer. So the IHC is performed, and after that, there are certain set of IHCs which are done to molecularly characterize the tumor. And broadly speaking, so we categorize the breast cancer into three types. So one is hormone receptor positive, HER2 negative breast cancer. The second is the HER2 positive breast cancer. And the third is triple negative, means estrogen and progesterone and HER2. All three receptors are negative. So we will discuss about it in the further slide. So these are the major classes of invasive ductal carcinoma. So first is the luminal A type. So this is the most common type of breast cancer. These are slow growing and they respond very well to the hormonal treatment. In this, so hormone receptor, they are positive, and HER2 receptor, they are negative. So this is the best as far as the outcome is concerned. But contrary to that, they are not very well responding to chemotherapy because of small proliferative fraction. So luminal B, it is again a subtype of luminal cancer. So where ER is positive, along with that HER2 is also positive. So these are comparatively having higher grade and proliferation rate, and these are the tumor which have good response to chemotherapy, and they can be treated with chemotherapy. Then the third type is normal breast like, so where hormone receptor is positive, HER2 is negative, and they have similar gene expression to normal tissue. So usually we do not we are not diagnosing these normal breast like with these hormone status. Usually these are the in practical, if you ask me, so the normal breast like these tumor, these are categorized either as luminal A or luminal B. Then comes the basal like. Most of the basal like tumor, they are triple negative. That means estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative. So they lack expression of marker typical to epithelial cell. They are having aggressive course, they frequently metastasize, and they have got a poor prognosis as compared to the other breast cancer subtypes. If we see the last variety, that is the HER2 positive, initially when this HER2 receptor were started to test, so at that time, HER2 positive breast cancer, they were having very, very poor prognosis. But nowadays, we have a lot of newer targeted therapies which are coming against HER2, the prognosis and outcome have improved. So broadly, treatment, it depends on whether the disease is local or systemic. Whenever there is local disease, so we have to deal with the breast cancer with local therapy along with adjuvant chemotherapy or radiotherapy. And systemic therapy, these are administered IV or orally to to destroy the cell which is present in the body elsewhere. So if we see about the treatment of breast cancer, once again, please. So these are certain definitions like neoadjuvant therapy, which refers to administration of therapy before surgery, and the goal is to shrink the tumor so that less extensive surgery can be performed. And adjuvant therapy usually is administration of therapy after surgery. So the goal is to eliminate cancer cells that may possibly have broken off from the primary. So these are regarding the micrometastatic disease which might be present, and with surgery we have just dealt with the local extent of tumor. We have not dealt with the metastatic sites. So these are the type of surgeries which are usually performed. One is the breast conservation surgery, where lumpectomy or quadrantectomy is done. and the other one is the mastectomy. So most of the times, this is the modified radical mastectomy which is done in most of the time, because radical mastectomy, it is a very cumbersome operation, and the simple mastectomy or total mastectomy, it is not a treatment of choice in breast cancer. But yes, simple mastectomy sometimes can be done, or in those with BRCA1 or 2 mutation positive status, where it is just to reduce the risk of development of breast cancer in future. So this is the lumpectomy, where only the lump is removed and the skin is not removed. The skin is inside, lump is removed, and skin is sutured back. And quadrantectomy, so where the tumor is removed and the in between the skin is also removed and remaining skin is sutured. So this is like removal of a whole quadrant of the breast. So if we talk about the mastectomy, whenever only the breast tissue is removed, it is called simple mastectomy. Whenever the skin is not removed, only the breast tissue is removed, it is called skin sparing mastectomy. And if along with the mastectomy, if the lymph node excision is also done, it is called modified radical mastectomy. And if along with these, the chest wall also is removed, it is called radical mastectomy. So radical mastectomy is something which was done in the past. Nowadays, it is not being done. So regarding the radiotherapy, it produces high energy rays or particle in order to kill the cancer cell, and it is mainly used after BCS in all the patients, or in after modified radical mastectomy in those where the tumor size is more than 5 centimeter, or where there are axillary lymph node metastasis. So there are two main mode of radiotherapy. One is external beam radiotherapy and one is brachytherapy. I don't think so we have to go in detail of these. So these are the systemic therapies which are available to treat the breast cancer. So for hormone receptor positive tumor, so these are the hormonal agents which are available. One is the selective estrogen receptor modulator, so which are tamoxifen and toremifene. Then is the aromatase inhibitor. These are particularly useful in those with postmenopausal breast cancer, and these the agents are letrozole, anastrozole, and exemestane. Then there are estrogen regulator receptor down regulator, which the molecule name is the fulvestrant. Then there are progesterone, which we can use, or ovarian ablation, which is another type of depletion of estrogen from the body. So apart from that, so mostly in adjuvant or neoadjuvant, as a adjuvant or neoadjuvant therapy, so the anthracycline and taxane, these are the most important chemotherapeutic agents which are used. And these are certain systemic targeted therapies which are available nowadays to treat the breast cancer. So these are mTOR inhibitor, like everolimus, then CDK4/6 inhibitor. These are the most important therapies and most effective therapies which are available to treat the metastatic CA breast, hormone receptor positive. Apart from the usage in metastatic disease, nowadays these molecules, these are also being tried in the early breast cancer setting. Then HER2 inhibitors, so these are again the advances which have happened in past, I think 15 years or so, so uh, which has led to improvement in HER2 positive breast cancer to a great extent. And there are various molecules which are available, like trastuzumab, lapatinib, pertuzumab, TDM1. Apart from that, there are a lot of new molecules which are coming against the HER2, like trastuzumab deruxtecan, then niratinib, then tucatinib. So there are a lot of molecules which are coming. So these are the systemic therapy. With this, I would like to conclude the talk, and I think we can take, if anybody is having any questions, so we can take down at this point of time.
Thank you, Dr. Parveen Jain. You have given an elaborate discussion and presentation on the diagnosis of breast cancer, how we can go for the screening modalities and the treatment modalities also of the breast cancer. So there are certain questions from the panelists. May I request Dr. Vijay Kumar sir to So you have to unmute, yeah.
First of all, I compliment Dr. Parveen Jain for a wonderful presentation, and he has covered all the aspects right from the screening and diagnosis and treatment. So my compliment to you, Dr. Parveen. And now the question is, see, I work in a department, railways department. I work as chief consultant in Northern Railway Central Hospital in Connaught Place. So before this, I was advisor held in the Ministry of Railways. We have got a large number of women workforce, which is working at different places across the country. Now, as far as screening is concerned, the facility of mammography, especially in the remote area, is not that easily available as ultrasound. Ultrasound is at least one modality which is available all across the country at all the places, even small towns, they have got ultrasound facilities. So can ultrasound be a replacement for mammography for screening purposes? That is my question.
Sir, I totally understand. So in our country, so a lot of people, they do not have access to digital mammography. There are certain limitations of ultrasound, which basically is the reason for why ultrasound has not become the standard of care screening modality. So first and foremost is the observer variation. So there are a lot of observer variation with ultrasound. So it is not reproducible. So one person might think that it is a Birat's 2 lesion, and the other person might think that it is a Birat's 4 lesion. Unnecessary. Usually it leads to a lot of confusion. These patients, again, they either, if they are having a Birat's 4 lesion and if it is reported as Birat's 2, so then these patients, they are not getting the proper treatment because of the categorization of this lesion into Birat's 2. And on the other side, so if the lesion which is practically is a Birat's 2 and it is categorized as Birat's 4, so unnecessarily that patient will be going ahead to the referral center. So where again whole lot of investigation will be done, and at one place if it is reported as Birat's 4, we will have to biopsy the lesion, because you have to take the highest category into picture whenever you are deciding about the biopsy and treatment. So
Right.
so it will increase the number of biopsies, it will increase the anxiety of patient. Either your radiologist should be trained so they are able to do ultrasound of the breast, and they are able to report according to the Birat's category, and it should be validated along with the digital screening mammography, that the lesions as per the ultrasound, it is almost equally placed as per the screening mammography. So this is something which we have to keep in our mind. Internationally, if we think, so ultrasound, it is not used as a standalone screening modality. It always complement the screening mammography.
One small question at this point. There were reports that because of this mammographic screening, there were increase in the number of false positive cases, which were subjected to unnecessary investigations later on. Is it so?
So the thing is that any sort of screening, so there are certain advantages of screening, there are certain limitations of screening. So whenever we are doing breast cancer screening, so definitely there is a tendency to overdiagnose, tendency to overtreat. Okay. So it definitely leads to increase in anxiety of the patient. But the thing is, after taking all these things into consideration, it improved the breast cancer related mortality. So
Right.
that is the crux. So that is why, and if you versus India, so in US, most of their cancer, they are screen detected, and almost 80% of their cancer, they are early stage cancer. And wherever, if you take the data from India, 50% of our cancer, they are loco-regionally advanced cancer. So where they unnecessarily require chemotherapy, radiotherapy. If you are able to detect cancer with the help of screening, so most of these patients, they will just require surgery and at the most some sort of chemotherapy. They will probably not require radiotherapy or like both the agents, anthracycline plus taxane, chemotherapy. So your amount of therapy definitely goes down when it is a screen detected cancer versus a symptom detected cancer.
Thank you. Thank you very much.
Now the second question is from Dr. Puneet Chandna.
Hello, good evening. Thank you very much, Dr. Sharma. And I must compliment Dr. Parveen. My name is Dr. Puneet, and I've been at the the ACTAC Center, TMC Mumbai, for quite some time, and work is in molecular and precision oncology. So thank you very much. Your presentation covered most of the points, right from the screening, diagnosis, then its treatment and modalities we may have for the surgery and so on, including the chemotherapies and the options available to women. My question, however, I'd like to retain it closer to the screening as the topic today. Like you said, the BRCA1 and BRCA2 mutations. Now we also see the P10 and the T53 mutations being promoted by the screening groups who have been making those guidelines. Likewise, we see the Gale models and other models which have been there. So now, in case I see, my question would be: in case we see the triple negative breast cancers, which are commonly nowadays found under the age of 40 as well, which does not have the first degree relative who is already suffering. We may not have many clues beyond the somatic or the environmental conditions. Now we are talking about under age 40. Not many guidelines are talking about even clinical examination, or they differ country wise. If I go by the FOXY guidelines, which have been last updated in 2018 by the Indian groups, they say even mammography should be done every other year, which would mean leaving 1 year in between and go every alternate year do this examination. So how do we catch up on the triple negative breast cancers, which are more sporadic in nature? And by the side, we may have patients who may have La-Ferroni syndrome or the Cowden syndrome, which may be picked up early, and we may lose on those patients, can be about 15 to 20% these days. So how do you recommend we should screen them?
So it's a very good question, Dr. Puneet. So regarding the answer, see, the thing is that most of the times when we talk about screening, most of the times it is related to average risk screening versus high risk screening. So whenever we are encountering any female with first degree relative or any history of any genetic component in the breast cancer, so then we have to start the screening 10 years prior to the earliest age at which in the member of family who got the breast cancer or some particular gene related cancer. So we have to start the screening at that particular age. If we see about the average risk, so average risk start at 40 years. So the thing which you were saying that every other year, so that is regarding the those patients who are more than 40 years. So there are USPSTF guidelines, so which suggest alternate, so biannual screening with mammography in those more than 50 year of age. And the rationale behind that is, so usually with increasing age, the chances of development of hormone receptor positive cancer, they increases. And these hormone receptor positive cancer, they are slow growing. And even if you are increasing the screening interval by 2 years, so there are not very high chances of developing screen failed interval cancers. So interval cancer is when we detect a cancer between the two screening the two screening time points. So those are called interval cancer. And the interval between two screening time points, it is mainly practically it is said that whenever the screen and the interval cancers, they are more, so like in triple negative cancers, they are aggressive tumor, So the chances of development of interval cancer is more in triple negative variety, but the triple negative variety, it is more common in the younger age group. So in more than 40 years, this is for the average risk. So where the initial 40 to 50, you can do a yearly mammography, and post 50 year, you can do a biennial mammography, just because most of these cancer, they are hormone receptor positive cancer. And whenever there is either P10 or cow10 or BRCA mutated cancers are there, so then you have to start the mammography plus MR screening 10 years prior to the earliest member. So I think this is the thing which, if anything else you want to ask, I think we can take down that.
Sure. There is one small question. We might have, early for all women who might be listening and, doing the Cancer Awareness Month, we may have changes which are cyclical and non-cyclical conditions for the breasts, which could be like the fibroadenomas, which is also causes the breast mouse, fibrocytic disease of the breast, maybe just a nipple discharge, which may be because of other reasons, bacterial mastitis, lipoma, and maybe other things. So how do you, what do you recommend as screening, and what are the, benchmarks before a gynecologist or the physician may turn the patients for the tertiary cancer screening at their clinics? Because we might miss, and we have a different side kind of setting in our country, because we might have big hospitals and we have different districts which may not have even a basic cancer screening modality in-house.
So for this, I think first and foremost thing is that the education of radiologists, the training of radiologists regarding to the BIRAT system. So that is very, very important. So the BIRAT system was came into picture to uniformly report breast imaging. So if a radiologist is tuned, so most of the time they are able to give the appropriate BIRATS category to these particular lesions. So if it is a BIRATS 2, we don't have to do anything. If it is a BIRATS 3, so usually what I do and what guideline recommend is that you have to repeat the imaging after 6 months. And if it is a BIRATS 4, definitely you will have to biopsy the lesion.
Great. Thank you very much. Thanks for your time.
Now, Dr. Diag from Bangalore, sir.
At the outset, it gives me great pleasure to Dr. Parveen Jain. It's a most wonderful, fascinating, and mind-blowing lecture. Even in a final exam-going final year MBBS student, or in a MS exam-going student or MCH, all after hearing your lecture, they can pass your pass, because you have covered everything right from A to Z. Thank you very much, sir. My simple question is, there are underdiagnosed these cases, especially breast cancer, by doing ultrasound. Nowadays, whenever we refer a case to radiologist, what they do, instead of using digital mammography, they do this ultrasound. You already said this ultrasound doesn't take up dense fibrous tissue where the breast this one. But unfortunately, most of the radiologists, because they themselves know what is the reason for that, they do this ultrasound. Digital mammography, if they use, I think they can find out. And today, MR plus digital mammography is most wonderful. In the villages, especially in the districts and taluks, it is very difficult because there are a lot of cases of breast cancer because of underdiagnosis. Will you throw some light on this, sir?
So, sir, regarding the ultrasound, we have already discussed that ultrasound as a standalone modality should not be used as a screening tool. So it should always be in addition to digital mammography. So I think we should. So most of the times, if you ask me, Indian guidelines, so they are not able to recommend digital mammography because of unavailability of digital mammography at the village level or at the taluka level. So there is definitely a challenge in getting digital mammography for everyone. But the thing is, at this point of time also, the most important and the standard of care modality is digital mammography, along with which ultrasound mammography can be used. Ultrasound, it has got its own importance in diagnosing a cystic lesion. So whenever there is a cystic lesion, it definitely is able to say whether it is a benign sort of cyst or it is a malignant sort of cyst. Again, in dense breast, usually ultrasound can be a complementary modality, but digital mammography, the sensitivity of digital mammography, it goes down whenever there is a dense breast. So that is why most of the times when we are getting a young uh, patient, so we have to get both of these done, digital mammography plus ultrasound mammography. Whenever we are facing a elderly individual, because most of the breast tissue, it is replaced by fat, and their digital mammography is a wonderful tool. It is able to diagnose almost all of the lesions as whether it is a malignant, appears to be a malignant or a benign. But apart from that, I think digital mammography, it still remains the modality of choice for screening.
Thank you.
Thank you, Dr. Yagra sir. Now, there is one last question from Dr. Damodar Lele in Q&A section. You can see to it. Why not perform open surgery with backup of frozen section study and decide about the extent of surgery there and there on the table? If negative, incision can be closed and removal of the benign lesion.
So, so this is a very, very good question, and I think I'll be very happy to answer that. See, nowadays, there had been many trials in the recent past which had suggested that whenever you give, first you have to molecularly characterize the tumor. Every biopsy, you should try to categorize the tumor as far as molecular categorization is concerned. And whenever you encounter a triple negative tumor or a HER2 positive tumor, so those are the tumor where a neoadjuvant chemotherapy followed by surgery followed by some sort of adjuvant therapy, it improves the outcome of the patient. And there is a term called pathological complete response. And whenever you get a pathological complete response with neoadjuvant therapy, it leads to improvement in overall survival also. So first point is this, that you have to decide, so what is going to be the sequence of therapy for our patient. So whether it will be surgery followed by some sort of adjuvant therapy, or whether neoadjuvant therapy followed by surgery. So this is regarding the why we need a pre-operative biopsy. Second thing, that in all the patient, you do not have to do excision biopsy, because most of the time core needle biopsy, it is easily performed. It doesn't have lot of risk. So there will be many patients who will ask you, by doing a biopsy, whether my risk of metastasizing the disease, will it increase? Yes, if you are doing incisional biopsy, so definitely there is an increase in risk of metastasis because of the biopsy per se. But whenever you are doing a core needle biopsy, the risk of metastasis is only to the tune of 0.4 to 0.5% of developing metastasis because of biopsy. So for these reasons, so incisional biopsies, they are not done nowadays unless and until the tumor is less than 2 centimeter in size, where you can directly proceed with the surgery. So which is called excisional biopsy. So incisional biopsy is now out of the scenario. You should not do incisional biopsies.
So, to conclude, Dr. Parveen, your presentation was extremely helpful for every one of us. And as an association now, we should go for more awareness about the breast cancer amongst the masses, amongst our workforce. And as you rightly said, what is important is breast self-examination, then breast clinical examination. And in case there is some doubt, then you should definitely go for some pineal aspiration cytology or true-cut biopsy or mammography or ultrasound wherever required as per the advice by the specialists. And now definitive uh, staging modalities are there, definitive treatment modalities are there. So we should not be hesitant in getting the breast cancer diagnosed as early as possible, because what we have seen that if it is diagnosed early and it is treated early, then it is definitely a curable disease, and you can come out of this cancer, and you can lead a disease-free life for quite a long time, or even throughout your life. So what is important is early diagnosis, for which we should, as an association, we should increase the awareness amongst the masses regarding breast cancer during this whole month of breast cancer awareness. So thank you very much, Dr. Parveen. We'll keep in touch. And now our next speaker is Dr. Rajiv Kumar Jain. And if you have time, then you can be there to listen to him, because he regularly updates us about the evolution of the pandemic. Dr. Rajiv Kumar Jain, in this special section today, he will be talking about this evolution of the COVID pandemic. Then is it time to reduce the waiting time for the second dose of the Covishield? Then Covaxin jabs for the children. Then scientific advisory group of origin of novel pathogens, global tuberculosis report also. Then a lot of new initiatives by Dr. Rajiv Kumar Jain sir. And Dr. Rajiv Kumar Jain is a senior consultant health in Indian Railways, and with 40 years of experience in health and hospital administration. His fellow award of the Indian Public Health Association and fellow award of awardee of Association of Environment and Occupational Health Delhi. And he has published and presented more than 145 scientific papers in national and international conferences and journals, and fellowship is scholarship from WHO and from various international organizations. And he's a known resource person for our association. Dr. Rajiv Kumar Jain sir, you can start your presentation.
Good evening, friends. Today, again, on a Saturday evening, after getting updated on cancer of the breast, we are now here to review the current COVID-19 epidemiological situation. And this is not only to learn about the COVID epidemiology, we also learn through this the epidemiology as a subject, as a specialty, which is so vital for all occupational health professionals. Besides COVID-19 epidemiology, we shall also be taking a review of latest development in COVID-19 in terms of COVID vaccine jabs for children, scientific advisory group for the origins of novel pathogens by World Health Organization, global tuberculosis report. In that context, we shall also take a review of COVID-19 and tuberculosis, and also a health argument for climate action, which is so important in the COVID pandemic situation. COP26, as you know, November, there will be global meeting in Glasgow, Scotland, where all the global leaders will collect for taking a review on the climate action, and health argument for climate action is very crucial. So we shall take a review of that also in this COVID-19 epidemiological updates. So we start with the basics, the global situation. Next slide, please. This is the global situation, and you are seeing the third wave is going down. Third wave is on the downslide, but nowhere near the reaching the ground. It is evolving, and you must understand, you must see the shape of the green color. Europe is now expanding once again, and you shall see in subsequent slides what is happening in Europe, specifically Russia and other Eastern European countries. Globally, the number of weekly COVID-19 cases and deaths have continued to decline since last August. Over 2.8 million new cases and over 46,000 new deaths were reported during the week of 4th to 10th October, representing decreases of 7% and 10% respectively as compared to the previous week. Apart from the European region, which reported a 7% increase in the number of new weekly cases as compared to the previous week, all the other regions reported declines in the new weekly cases. So here we are back to Europe. Here we started 1 year, 9 months back from Europe. Here we are again in Europe. The largest decrease in new weekly cases was reported from the African region, that is 32%, followed by the Western Pacific region, 26%. The cumulative number of confirmed cases reported globally is now over 237 million, and the cumulative number of deaths is over 4.8 million. The number of new weekly deaths reported showed a large, that is more than 10% decline for all regions, except for the European regions, which reported an 11% increase as compared to the previous week. The largest decline in weekly deaths was reported from the Western Pacific region and the African regions, with both showing declines of 34% as compared to the previous week. Let's see the data as such for the week-on-week situation. Next slide. This is the newly reported cumulative COVID-19 cases, and you see out of 100 cases, that is 28,85,000 cases reported globally, the largest contribution was from Europe, and it's not America which is contributing largest. Europe reported 44% of the 28,85,000 cases globally. 9,49,000, that is 33% of cases were from Americas. Southeast Asia 9%, Eastern Mediterranean 5%, Western Pacific 9%, and Africa only 1%. And if you see out of all the regions, 7 days to 7 days, 7% increase was in Europe, all other regions showing minus figures, and larger decrease, Western Pacific region minus 26%. For the deaths also, out of 100 deaths, if you see 37 deaths were from Europe and 40 deaths from America. But if you see the trend from week on week, 7 days to 7 days, it is 11% increase in Europe and all other regions showing negative. Globally, overall 10% decrease. Let's see now the ranking of the countries. And before that, we see the graph, the evolution of the pandemic across different regions of the World Health Organization. And what do you observe? You observe that at least in Americas and Europe, there is no sign of reaching to zero at all. In fact, if you look at the graph of Europe, that is light green, you find a sudden jump up. The third wave is now going up again in Europe. And if you look at the graph of Africa, it is going down. If you look at the Eastern Mediterranean region, it is inching towards zero. Southeast Asia, definitely it is going down, but not yet reached zero. Western Pacific, yes, it is on the downslide, but we have to see what happens in the next few weeks. Next slide. This is the ranking of the regions of the world in World Health Organization with COVID cases newly reported last 7 days. Highest from Europe, 13,60,000. This is the absolutely latest coronavirus disease dashboard with 28,08,000 cases globally, and America's 8,43,000, Southeast Asia 2,21,000, Eastern Mediterranean 1,31,000. And if you look at the last 24 hours, 2,13,000 cases were from Europe, 1,28,000 from Americas, and other countries showing less than 27,000 or 31,000 cases. If you look at the deaths, highest number of deaths are occurring in European region in the last 7 days, 18,000 deaths out of 45,000 deaths globally. And again, if the last 24 hours, more deaths have been from America than Europe, and both the regions are showing more than 2,500 deaths last 24 hours. Next slide. Let's look at the ranking of the countries. In the last 7 days, highest number of cases were from United States. Second, United Kingdom, 271,000. Turkey, 213,000. And for the first time, Russia has been reporting more than 2 lakh cases in 7 days, with 32,000 cases reported in the last 24 hours. India is reported 1,22,000 cases, Romania 98,000, and Ukraine 96,000. So in the top 7 countries, we find now United Russian Federation, Romania, and Ukraine, all very close to each other. They are the epicenter of growth of COVID pandemic now in the world. This is a ranking in terms of deaths in the last 7 days, with highest deaths being reported from the United States, 10,000, Russian Federation, 6,800, last 24 hours, almost 9,999, and Mexico is number 3 with 2,500 deaths, Brazil, 2,200 deaths, Romania, 2,200 deaths, Ukraine, 2,056 deaths, and India, 1,687. Out of these top seven countries, least number of deaths have been in India. And if you look at, again, Russian Federation, Romania, and Ukraine are becoming the epicenter of growth of COVID-19 and where deaths are occurring. Next slide. This is the COVID-19 cases per 1 lakh population, and you are seeing the darker color of Russia and other Eastern European countries. The Eastern Europe is now facing the brunt. The darkest color in the world is in that region, including Russia, which is encompassing Europe and Asia. Next slide, please. Again, you find, if you look at the COVID-19 deaths per 1 lakh population, which are the area of the globe which is seeing the highest number of deaths per 1 lakh population. It is the Eastern European region and Russia, including Russia. Next slide, please. This is the Southeast Asian region where India is situated. This is the condition today. Southeast Asia region reported 2,47,000 new cases and over 3,600 new deaths, and 11% and 16% decrease, respectively, as compared to the previous week. All countries reported a decrease in weekly new cases and weekly new deaths this week, with the greatest decrease reported from Timor-Leste. Overall, cases and deaths have continued to decline since early August. The highest number of new cases were reported from India, that is 1,39,000 with 13% decrease, Thailand 73,000 with similar to last week's figure, and Myanmar 1,10,188 new cases, which is similar to last week's figure. The highest number of new deaths were reported from India, that is 1,772 new deaths with 7% decrease, Thailand 677 new deaths with 9% decrease, and Indonesia 478 new deaths with 32% decrease. So overall, every country is showing decrease in cases and deaths. Next slide. Now we come to India. This is a snapshot of last 24 hours, 16,000 new cases. After a long time, it is nearing 15,000 new cases every day. 163 deaths and 9.2 lakh tests done yesterday. 7-day average test positivity is now come to be 1.5 after a long time. Active cases are reduced to less than 2 lakhs. That also very long time. We never saw less than 2 lakh active cases, and is shrinking by 2.3%. Total 3.4 crore cases, 4,52,000 deaths have occurred till now. 97.19 crore vaccination doses have been given, and we are inching towards a landmark figure of 100 crore. Shortly, within the next 7 days, we are likely to reach 100 crore vaccination doses in India. Who could think that India can administer 100 crore doses by middle of October or by third week of October, of reaching before October crossing 100 crore is a landmark achievement. 8 lakhs doses were given yesterday. Next slide. This is the snapshot of the country in terms of states, ranking of the states, in terms of confirmed cases, deaths, tests per million per day, 7-day average test positivity rate, 7-day average daily growth in percentage, and vaccinated persons with at least 1 dose in percentage. And we find confirmed cases highest is Kerala with 5,667 cases out of 16,000 cases. Maharashtra, Tamil Nadu, Mizoram, Andhra, and Karnataka are in the top 5 states in terms of confirmed cases. In deaths, we find out of 183 deaths, 57 deaths were from Kerala, Maharashtra, Tamil Nadu, Karnataka, Andhra, and West Bengal are the top 5 states which at the last 24 hours. Tests per million per day, highest are being conducted in Mizoram, Jain, Delhi, Goa, and Kerala, while lowest are being conducted in Uttar Pradesh, Rajasthan, West Bengal, Chhattisgarh, and Nagaland. 7-day average test positivity rate. Look at the high number of test positivity rates in Mizoram, 15.6, and Kerala, 11%, Manipur, 5.3%, Sikkim, 4.8%, Meghalaya, 3%, Nagaland, 2.9%, and West Bengal, 2.4%, while Indian average is only 1.5%. If you look at the 7-day average daily growth, Indian average is 0.05%, Mizoram is showing 0.94, Kerala is 0.19, Manipur 0.10. So these are the states where it is still there. Kerala, Mizoram, and northeastern countries, northeastern states. Vaccinated persons with at least 1 dose in percentage, Indian average is 50.96%, while in Nagaland is 31%, Meghalaya 33%, Jharkhand 37%, and Bihar 38%. Next slide. This is the global march of the variants of concern. Alpha has reached to 195 countries. Entire world is now orange. Beta is 145 countries. Very few countries you see in white. All are in blue. Now it's in, if you see Gamma in 99 countries, Africa and parts of Europe is left out. While if you see Delta, it is in 191 countries. All the world is violet with Delta variant, except a part of North Africa and a part of South America is white. All other part of the world is now violet. And also please note, India is having all the 4 variants of concern: Alpha, Beta, Gamma, and Delta. Next slide. Now we shall consider a very important question. Is it now time to reduce the waiting time for the second dose of Covishield? India on May 13 increased the waiting period between 2 doses of Covishield vaccine from 4 to 8 weeks to 12 to 16 weeks. The idea back then was to administer the first dose of COVID-19 vaccines to as many people as possible. At 6 p.m. on 12th of October, Covishield accounted for 88% of COVID-19 vaccine doses administered in the country. But with a decline in registrations as well as the number of first doses of the vaccine administered, is it time to reduce the gap between the 2 doses of the Covishield vaccine? Let's examine that. Next slide, please. The proportion of first doses has started decreasing. The first dose is in blue and second dose is in orange. The COVID dashboard provides data on daily vaccination by first and second doses. The number of first doses has been falling consistently since September 17. The proportion of the first doses in total doses has been declining since late August. This is the 3rd time since May that this proportion has decreased, but is perhaps the most significant because the number of those vaccinated may be nearing an important milestone. This is the 7-day average rolling average that you're seeing in this graph. Next slide, please. Have vaccinations in India hit a ceiling? Let's examine that. On the left is the number of days taken for successive 10% coverage of adult population. First 10%, 88 days, then 56 days, then 25, 32, 23, 17, 21 and 8. And now 60 to 70%, 21 days only, and 50 to 60%, 17 days only. And you see consistent decline from 30% onward. India's projected adult population in March, as per National Commission on Population Report, was 940.2 million. By October 11, 684.1 million have received their first dose of COVID-19 vaccines. The share of the adult population that has received at least one dose is 73%. Comparing the time taken to provide the first dose for each 10% of India's adult population, the increase in coverage from 50% to 60% between August 18 and September 13 was the fastest. This pace has slowed since then. The weekly average of first doses administered in the week ending October 9 is the lowest since the week ended July 29. It will likely slow down even more. Let's look at the new registrations at the weekend. The slowdown is on account of low demand is evident from data on number of registrations on the COVID dashboard. The dashboard gives a combined number for online and offline registrations. After the week ended September 17, there has been a consistent decline in new registrations in that week. There were 39.36 million registrations. In the week ended October 8, new registrations were 58% of that number, 66 million. There has been one more such period of consistent decline since May 1, which vaccinations were when vaccinations were opened up for all adults. In the week ended July 16, new registrations were only 45% of the new registration in the week ended June 25. Still, when seen along with the fact that 73% of the eligible population has received at least one dose, the reason for the recurrent decline is evident. Let's see the third data set. The states with the higher first dose coverage are showing a bigger fall in new vaccinations. First dose coverage is related to change in the pace of vaccinations. In the blue, you are seeing the share of adults vaccinated with at least one dose. And on the red, you are seeing the ratio, daily rate of first dose vaccine administered since September compared to May to August. And what you're seeing on the red, you're seeing a sharp decline. And you are also seeing the number of registrations across states is not available from the COVID dashboard. However, growth rates of new first doses across states have some correlation with coverage. Himachal Pradesh has given first doses to its entire population. According to the 2021 population projections, here the overall rate of first doses delivered since September 1 is 4,591 per day, which is 15% of the rate in the May to August period. In West Bengal, where only 65% of the adults have been given at least one dose, the overall per day rate of first doses since September is 2.5 times the rate in May to August. So that is the major difference that we find. Now, is it time to expedite the second doses? The decision to prolong the gap between the first and the second dose Covishield was motivated by supply constraints. Data on falling demand for the first dose of COVID-19 vaccines shows that India might be reaching a point of moderation in demand for the first dose. Can this window be utilized to accelerate the process of administering second doses and boost immunity levels against the pandemic? So that will be the advantage which I think the government should examine and reach a scientific decision. Let's examine another issue. Next slide, please. Now, as you know, Covaxin has been authorized. Covaxin jabs for children. We would first apprise what is all the health professionals should be knowing. The subject expert committee of the Central Drug Standards Control Organization had recommended granting emergency use authorization to Bharat Biotech's Covaxin for vaccination of 2 to 18-year-olds against COVID-19. The vaccination status is shown in the two graphs. Age breakup doses given so far is 18 to 44, 54, 55%, 45 to 60, 27%, and 60 plus is 17%. Next slide. What is the panel recommended? The subject expert committee has recommended emergency use of Covaxin for children under COVID-19 National Immunization Program. Bharat Biotech has submitted data from clinical trials in the 2 to 18 years age group to the CDSCO. The data has been reviewed by the CDSCO and the SEC, who have given positive recommendation. The trials showed that the safety and immunogenicity of Covaxin are almost the same in children and adults. As the recommendations are subject to certain conditions, the SEC said the firm should continue the study as per the approved clinical trial protocol. Why is vaccinating children important? In India, a third wave of coronavirus infections are anticipated. This wave may impact children as they are the only population group left unvaccinated. India has more than 50% of its population below the age of 25. The 0 to 14-year age group constitutes 28.6% of the total population. The Drug Controller General of India has already given the emergency use authorization to the world's first DNA vaccine by Zydus Cadila, which will also be used to vaccinate 12 to 18-year-olds. Vaccination of children may lead to the reopening of more schools and colleges and thereby cut the learning losses. Next slide. What are the next steps in terms of regulation? The next step is for DCGI, CDSCO to go ahead with the regulatory approval. In the private markets, the vaccination would depend on pediatricians and parents, according to Bharat Biotech. Meanwhile, the Union Health Ministry has said that India may start inoculating children against COVID-19 from October. However, an official announcement is awaited. Next slide. Why should one trust Covaxin for kids? Bharat Biotech has completed phase 2 and 3 trials of Covaxin on children below 18 years of age. Covaxin is already approved for adults and in clinical trials has demonstrated 77.8% efficacy against symptomatic coronavirus disease and 93.4% against severe symptomatic COVID-19. Clinical trials were carried out among 3 age groups, 12 to 18 years, 6 to 12 years, and 2 to 6 years. The final results of these trials are awaited and the interim results have been submitted to the drug controller. What sort of Covaxin stocks are needed? The 2 to 18 years age group in the country is estimated at about 400 to 500 million. So the company would need to produce twice as many doses. In September, Bharat Biotech said it will scale up production from 35 million to 55 million doses in October. The firm has partnered with Indian Immunologicals and Hester Biosciences to ramp up production. The capacity to increase to 100 million doses if all safety parameters are in place and the manufacturing partners are prepared. Next slide. Now, the government of India will take a final call. Lack of data is definitely a worry. There has been a lack of adequate data. Covaxin's phase 3 clinical trials are not yet peer reviewed. The shot also is yet to be approved by World Health Organization. These factors could make parents reluctant. The company may have to keep submitting adverse effect data every 15 days for the first 2 months. A list of comorbid conditions could determine which children become eligible first. COVID vaccines for children in India at the moment, only 4 are on the horizon at present. That is number 1, Zycov-D of Zydus Cadila, approved for use in age groups 12 and above, in line with trials, not yet included as part of the vaccination drive. Covaxin of Bharat Biotech, recommended for use in ages 2 and above, not yet included as part of the vaccination drive. Third is Corbevax of biological E, cleared for trials in children aged 5 to 18 years. And the fourth is Covovax of Serum Institute of India. It is cleared for trials in children aged 2 to 18 years of age. So now you know a lot about Covaxin and other vaccine pipeline for children from 2 to 18 years of age. The government of India at the moment is examining the logistics as well as the possibility of introducing on a very controlled manner for a limited group of children, especially children having comorbid conditions. So the government of India shall be shortly declaring the comorbid conditions for which children may be eligible to get the vaccine, which are already authorized as emergency use authorization. Let's examine another issue now. Next slide. This is the current situation for the week. Tamil Nadu and Jharkhand are lagging behind in jabs for 45 plus age group. India's COVID-19 vaccination rollout for the general public was designed to cover its elderly first. Those above 60 years of age starting getting their jabs from 1st of March and those over 45 from 1st of April. But half a year down the line, India has given 100 population in the 45 plus age group against the required 200 doses per 100. For Jharkhand and Tamil Nadu, the number is less than 100 doses, while Uttar Pradesh, Bihar, and Punjab crossed the mark only this week. Worryingly, the pace of vaccination coverage in these states has slowed down to data which is showing. The country has prioritized the 45 plus age population because the severity of the infection tends to be higher in this age group. Vaccination brings down chances of hospitalization and death. A recent study by Public Health England showed that even against the Delta variant, Covisshield's efficacy was 33% with a single dose and 60% with both the doses. India does not publish the first and second dose breakup by age groups. However, assuming that the 430 million doses given to this age group covered the first dose for all 345 million people over 45, it would mean 75% have not received their second jabs yet. The 5 low-performing states, which have together given only 101 doses per 100 population, account for 39% of India's 45 plus population. Further, in these states, vaccination coverage grew 4% last week, slowing down from 7.4% 4 weeks ago. In Jharkhand and Tamil Nadu, which have the lowest vaccination coverage at 90 and 92 doses per 100 people, respectively, growth was even slower. And you are seeing in the graph, the same data is evident. Next slide. Now, if you look at the world, how world is vaccinating, Indonesia has retained the top spot in vaccination coverage growth. India's weekly vaccination coverage growth slowed down to 4.1% this week compared to 5.7% a week earlier. It has retained its 4th position among the most populous countries for the 3rd week now. Indonesia and Bangladesh have maintained their top spots. Indonesia has now given 58 doses per 100 population, up from 54 doses per 100 population a week earlier. Earlier this week, it received 688,800 AstraZeneca doses from France under COVAX. It has also approved the 3-dose Chongqing Shifei biological products vaccine, making it the 4th Chinese vaccine cleared for emergency use in the country. The World Health Organization recommended that those above the age of 60 who have received 2 doses from Chinese maker Sinovac and Sinopharm get a 3rd booster dose. These 2 vaccines have so far been approved for use in 105 countries, all in the middle and low income category. So 3rd dose will be required for the 2 Chinese vaccines, Sinovac and Sinopharm. Next slide, please. Now about the festive concerns. 438 districts reported 10 or fewer cases in the last 7 days. India reported 1,27,506 new COVID-19 cases in the last 7 days, its lowest in a week since the beginning of March. Kerala constituted 54% of all new cases that were reported in the country for the last week, down from 56% in the PCD week. The number of new infections dropped in all 14 districts of Kerala for the 2nd consecutive week. The other hotspot, Mizoram, also reported a decline in cases for the first time in 18 weeks. It reported 8,380 new cases this week, down from 9,408 cases last week. West Bengal and Odisha were the only 2 states that reported an increase, up by 6.3% and 9.5% respectively. 14 of the 23 districts in West Bengal reported a rise amid festivities, while Kolkata crossing 1,000 new cases for the first time in 15 weeks. So red signal from West Bengal and Odisha. 8 of the 31 districts in Odisha have reported over 100 cases each this week. Next slide, please. A look at the deaths. Kerala and Maharashtra reported fewer deaths last week. India reported 1,586 COVID-related deaths this past week, 11.4% fewer than the previous week. 16 states and union territories have reported a decline in the number of deaths. 6 reported no change, while 10 had 0 deaths. Kerala continued to report the highest number of deaths, that is 760, even though it was down 10.2% from 2 weeks ago. Maharashtra is at a distant second with 308 deaths. 3 northeastern states, that is Assam, Meghalaya, and Mizoram, along with Gujarat and Himachal Pradesh, are the only ones to have reported a rise this week in deaths. Only 12 districts in the country have reported 50 plus deaths this week, 9 from Kerala and 3 from Maharashtra. 8 of these 12, including 7 from Kerala, reported fewer deaths this week. Thiruvananthapuram has reported 109 deaths, up from 60 last week, and is the only district to report more than 100 deaths. And you're seeing the same data on the graphs. Let's look at now another issue of importance this week. World Health Organization announced proposed members of its scientific advisory group for the origins of novel pathogens, that is SAGO. Next slide, please. Following a public call for experts, World Health Organization announced proposed members of the WHO Scientific Advisory Group for the origins of novel pathogens, that's SAGO. The SAGO will advise WHO on the development of a global framework to define and guide studies into the origins of emerging and re-emerging pathogens of epidemic and pandemic potential, including SARS-CoV-2. So it is not only for COVID, it is for other future emerging pathogens. The emergence of new viruses with the potential to spark epidemics and pandemics is a fact of nature. And while SARS-CoV-2 is the latest such virus, it will not be the last, said Dr. Tedros Adhanom Ghebreyesus, WHO Director General. Understanding where new pathogens come from is essential for preventing future outbreaks with epidemic and pandemic potential and requires a broad range of expertise. We are very pleased with the caliber of experts selected for SAGO from around the world and look forward to working with them to make the world safer. Selected from more than 700 applications, the 26 proposed SAGO members have expertise in a range of areas including epidemiology, animal health, ecology, clinical medicine, virology, genomics, molecular epidemiology, molecular biology, biology, food safety, biosafety, biosecurity, and public health. The composition of the SAGO reflects geographic and gender diversity. As per WHO processes, there will now be a 2-week public consultation period for WHO to receive feedback on the proposed SAGO members and set in place the modalities for the SAGO's first meeting, which is planned to take place following this consultation period. The final membership to the SAGO is subject to the above-mentioned public consultation period and relevant WHO practices and procedures. Next slide, please. Functions of the SAGO are first, to advise WHO on the development of the WHO global framework to define and guide studies into the origins of emerging and re-emerging pathogens of epidemic and pandemic potential. Second is to advise WHO on prioritizing studies and field investigations into the origins of emerging and re-emerging pathogens of epidemic and pandemic potential, in accordance with the WHO global framework described in point 1 above. First is to provide information and views to assist the WHO Secretariat in the development of a detailed work plan for the SAGO. Second, in the context of SARS-CoV-2 origins, first is to provide the WHO Secretariat with an independent evaluation of all available scientific technical findings from global studies on the origins of SARS-CoV-2. And second, to advise the WHO Secretariat regarding developing, monitoring, and supporting the next series of studies into the origins of SARS-CoV-2, including rapid advice on WHO's operational plans to implement the next series of global studies into the origins of SARS-CoV-2, as outlined in the joint WHO-China global study of origins of SARS-CoV-2. China part report published on 30th March 2021, and advise on additional studies as needed. And third, to provide additional advice and support to WHO as required, requested by the WHO SAGO Secretariat, which may include participation in future WHO international missions to study the origins of SARS-CoV-2 or for other emerging pathogens. A very wide sweep of responsibilities and functions have been given to SAGO. Very important development. Next slide. This is the public notice of the proposed new scientific advisory group for the origins of novel pathogens members. Next slide. There are 26 members. Number 1, Dr. Philip Albiola, Associate Professor, Animal Biology Division of Institute of Biological Sciences, University of Philippines, from Philippines. Dr. Abdullah Asiri, Assistant Deputy Minister for Preventive Health at the Ministry of Health, Saudi Arabia. Dr. Stuart Blaxell, Professor of Tropical Microbiology at Newfield Department of Medicine at University of Oxford. He's from Australia. Dr. Inger Damon, Director of the Division of High Consequence Pathogens and Pathology at United States Center for Disease Control and Prevention, originally from USA. Dr. Vladimir Dedkov, Deputy Director for Research at the Pasteur Institute in Russia, from Russia. Dr. Christian Drosten, Professor and Head of Institute of Virology at Charity in Germany. He's from Germany. Dr. Elmo Bazar Farag is a Senior Infectious Disease Epidemiologist and Head of Communicable Disease Control Program at Ministry of Public Health in Qatar. He's from Sudan. Dr. Thea Fischer is a Professor of Virology at the University of Copenhagen, Head of Clinical Research at Norge Hospital in Denmark, and she's from Denmark. Dr. Raman Gangakhetkar from India. He is the Dr. C.G. Pandit National Chair at the Indian Council of Medical Research in India. Next slide, please. Dr. Maria Guzman is the Head of Center for Research, Diagnostic and Reference at the Institute of Tropical Medicine, Pedro Correa in Cuba. Dr. Christian Happy, Professor and Director of African Center for Excellence for Genomics of Infectious Disease, Redimers University, ED, Nigeria, from Cameroon. Dr. Marion Koopmans, Professor and Head of the Department of Viroscience at Erasmus MC. She's from Netherlands. Dr. Swat Lee is Deputy Head of Epidemiology and Public Health Unit at Institute Pasteur du Cambrai, is from Cambodia. Dr. Jean-Claude Manuguera is a research director of the Environment and Infectious Risk Unit, as well as the head of the Emergency Biological Intervention Unit at Institute Pasteur in France. He's from France. Dr. Keen Mint is the head of the Emerging Virus Research Unit at Ashman Institute for Molecular Biology in Jakarta, Indonesia, from Myanmar. Dr. Carlos M. Morel is director of the Center for Technological Development in Health as the Oswaldo Cruz Foundation, Ministry of Health, Brazil. Dr. Yung Wee is co-program leader of the Animal and Human Health Program at the International Livestock Research Institute in Kenya. He's from Vietnam. Dr. Chinwe Ochu is an associate professorial fellow at the Center for Excellence for Migration and Global Studies at the National Open University of Nigeria. Dr. Masayuki Saijo is director of the Medical Planning Department, Sapporo City Health and Welfare Bureau of Sapporo, Japan. He's from Japan. Dr. Rosemary Sang is advisor and chief research officer at the Center for Virus Research, Kenya Medical Research Institute, Kemri, Kenya, from Kenya. Next slide, please. Dr. Katharina Sumer-Mata is head of the Biosafety Center and managing director of the Biosafety Level 3 Laboratory at the Institute of Infectious Disease and University of Bern in Switzerland, from Switzerland. Dr. Marietje Venter is professor of the Zoonotic Arbovirus and Respiratory Virus Research Program at the Center for Viral Zoonosis, Department of Medical Virology at University of Pretoria, South Africa. Dr. Supapon Wacharupale is a researcher at the King Chulalongkorn Memorial Hospital, the Thai Red Cross Society, and a committee member of the Chula School of Global Health, Faculty of Medicine, Chulalongkorn University, from Thailand. Dr. John Watson, honorary professor at the Faculty of Epidemiology and Population Health, London School of Hygiene and Tropical Medicine, as well as a visiting professor in the Research Department of Infection and Population Health at University of College of London, from UK. Dr. Yung-Wee Yang is the Deputy Director of Beijing Institute of Genomics at the Chinese Academy of Sciences in China. He's from China. So all the listeners and anybody who wants to comment, all the public of the world is welcome to give comment to the email sago@who.int with the subject public comments on SAGO members by 27th of October. Please remember, last date is 27th of October on any of these 26 persons who have been nominated as SAGO members. Here, now I share with you one video from World Health Organization regarding SAGO.
Following a public call for experts, WHO today announced the proposed members of the WHO Scientific Advisory Group for the Origins of Novel Pathogens, or SEGO. The 26 experts were selected from over 700 applications and were chosen for their world-class expertise and experience in a range of disciplines, as well as their geographic and gender diversity. SEGO will advise WHO on the development of a global framework to define and guide studies into the origins of emerging and re-emerging pathogens with epidemic and pandemic potential, including SARS-CoV-2.
SEGO, is there a plan?
And what we need this group to do is to urgently assess where are we in what we know and what we don't know and what urgently needs to be done. Following the last mission to China, there were more than 36 recommended studies that needed to be carried out. We hope to get an update on those studies as well, so that we can say, okay, here's what's next. So this advisory group will provide advice to WHO on those urgent next steps, and then WHO will work with any member state, including China, to carry out what needs to be done.
Undertaken in China. Do you anticipate that?
But I want to make it very clear that the SEGO is not the next mission team. There's been some misrepresentation about that going forward. It's an advisory group to WHO. Of course, they're going to make recommendations on missions that will be needed. And also remember that the SEGO is not just for the current pandemic, but for future pandemics or future outbreaks, future emergence as well. And so I would expect that this group would make recommendations for field studies that are necessary to be carried out.
Emergencies, Dr. Maria Van Kerkhoff, technical.
After 11 months of conflict, the humanitarian crisis in northern Ethiopia is growing worse
we will take
by
up
the
another
day.
subject now. We go back to the presentation. Another important event which happened during this week and which is relevant to COVID-19 was this. Let's see the slide. That is a global tuberculosis report. Next slide. The fight against tuberculosis takes 2 steps back due to what? COVID-19 pandemic.
If you're living with TB,
So we are
what
looking
is
at-
your risk from
Let's look at
COVID-19?
this
How
video
can
for tuberculosis and COVID-19. Then we come back to this slide.
If you're living with TB, what is
Video
your risk from COVID-19? How can you keep yourself safe during the pandemic? And why is it important that the world doesn't take its eyes off of TB during the pandemic? Hello and welcome to Science in 5. I'm Vismita Gupta-Smith. We are speaking with Dr. Teresa Kasayeva today. Welcome, Teresa. Teresa, let's start with what is the risk for a person living with TB from COVID-19?
Both tuberculosis and COVID-19 affect primarily lungs, though tuberculosis is caused by bacteria and COVID-19 by virus. Keep in mind that tuberculosis is everywhere and can affect anyone, though we know that there are a group of high TB burden countries where the risks of getting tuberculosis are much higher. Also, we should keep in mind that over than a quarter of the world's population is infected with the mycobacteria. It means that you are not sick and you cannot transmit infection, but you have higher risk of development tuberculosis. And when we are in the midst of the COVID-19 pandemic, these risks increasing. Evidence on TB and COVID-19 is still emerging. We're still studying on it. But we can say that patients with TB, in case if they've got COVID-19, will have more severe COVID-19, and in the same time, the risk of less successful treatment for TB is higher.
Teresa, why is it important that the world doesn't take its eyes off of TB, even during a pandemic?
Tuberculosis remain one of the biggest infectious disease killer right after COVID-19. Tuberculosis is everywhere. It's airborne infection and it doesn't know borders and nations. Every single day, tuberculosis claims more than 4,100 lives. And even during our Science in 5 talk, over 15 people lost their lives. Every year, around 10 million people falling ill with the tuberculosis. And due to the current situation and disruption of the essential services, we can see significant drops in TB diagnosis notification, and it means that access is limited. And it means also that people are not receiving timely life-saving treatment, and transmission of the infection is continued. We have all the opportunities, even during COVID-19 pandemic, to combat successfully both diseases and protect better people. Let's keep our eyes on tuberculosis.
Teresa, if you're a person with TB, how can you keep yourself and your loved ones safe during the pandemic?
Follow your doctor advice and keep your place where you live with your family well ventilated. Follow the principles of the good hygiene. Especially, it's well known for people with tuberculosis how it's important to follow cough etiquette, wear masks appropriately, keep social distancing, and if vaccines are available, please be vaccinated. Get yourself tested for both COVID-19 and tuberculosis. If you have symptoms like coughing, high fever, difficulties in breathing, remember that both diseases can have similar symptoms. Also, please keep in mind the fact that you should be tested for TB if you have history in your family or close contacts with the TB, and you've been tested with the TB infections. The risks during pandemic are growing. Remember that tuberculosis is preventable and treatable disease. Please keep yourself and your family members safe and healthy.
Thank you, Dr. Teresa Kasayeva. That was
That's all. So after getting an update on COVID-19 and tuberculosis, we understand how important these two related issues are. But much more important than tuberculosis, COVID-19 is the pollution level, the climate action. And in November, all the global leaders, including our Prime Minister, shall be meeting in Scotland, Glasgow, where important update or important decisions shall be taken regarding climate action. I will share with you one important aspect of a special report on health arguments for climate action. Let's look at the video and then see how it is relevant to COVID-19 pandemic. And occupational health, by the way, in United World Health Organization is handled by a doctor who handles climate action as well. Dr. Maria Nera is head of occupational health also in World Health Organization.
As you well know, in few weeks we will have the COP26, and everybody says that this COP has to be special, especially in the level of ambition and solutions and action and interventions proposed, political courage as well, and exceptional in the speed at which those decisions needs to be taken. And this is why the health community broadly, because it's WHO, of course, but behind and in partnership with WHO, there are many, many health professionals in the broad sense that decided to join us on this call for putting the health argument really at the center to accelerate the negotiations at COP26 in Glasgow this year. So we all hope that this recovery after COVID-19 could incorporate our health arguments, because we are convinced that the health will be the motivation to do much more and to accelerate action on climate change. The good news,
T21, and it's 5 o'clock.
We have 45 million health professionals joining us on this call for a COP26 with the health argument at the center, and where health will be benefiting for all of the action that needs to be taken. The number is growing every day, so it's just 45 million today, but I'm sure it's growing.
Welcome you to today's press conference, a virtual press conference.
What is the health argument? Well, the health argument for COP26 for climate action is the following. We know that climate change is affecting our health. That has been clearly demonstrated. Diag maybe later can elaborate a little bit more on that. But we know very well that climate change is affecting the pillars of our health: food, water, the quality of the air, and shelter. So as you can imagine, all of that will represent a major risk for our health. And therefore, we need to invest on adaptation to climate change, on more resilient healthcare facilities and systems, and a more resilient society. But the positive message on the health argument is that whatever you do to tackle the causes of climate change will have enormous benefit for the health of the people.
The health argument for climate action.
One of the big constraints that is often put forward for climate action is that it costs money. In fact, if you take into account the health gains, it saves money. IMF recently came out with a report that estimated that we are currently, as the globe, financing the fossil fuel industry to the tune of about $5.9 trillion a year. That's about $11 million a minute. And about half of that is the unpaid health costs of air pollution and so on. So we can save that money, get the health gains if we were to put it into healthier energy systems.
The Assistant Director General for Universal Health Coverage and Health.
Healthcare professionals have, of course, been at the forefront of responding to COVID. They've seen up close, and often far too personally, the impact of a lack of preparedness of our health systems on their health as well as on patients. And it is why they have seen how investing in health rapidly also impacts on our whole way of life. Healthcare professionals have said to me, if you think COVID is bad, when it comes to climate change, you ain't seen nothing yet. It's the grandmother of all health threats. COVID and climate change are compounding each other, and they're adding pressures on already weak health systems and staff. And it's why business as usual is not an option. And it's why now we need to truly have health at the centre of all our policies: energy, transport, agriculture, water and food.
Thank you. So we now understand, when we study epidemiology of COVID-19, we also study the way the world is changing, the way the world is impacted with COVID-19. COVID-19 is just an entry to One Health. The whole scenario, the whole meaning of health is going to change post-pandemic. One Health is the central focus. That's why SAGO has been formed. That's why climate action is there. And that's why tuberculosis, HIV, and pandemic will coalesce together. In the last, I shall share the last Nobel Prize, the other Nobel Prizes I shared last week in medicine, physics, chemistry, literature, and peace. But the last prize is for economics. The 3 US-based economists who have been awarded the economics prize for this year is for societal research. And these awardees, this year's Nobel Prize in Economics has been awarded jointly to 3 American economists. David Card, a labor economist at California Berkeley, has received half of the prize money, while Joshua D. Angrist and Guido W. Imbens, economists at MIT and Stanford University, will share the other half of the prize. The Nobel Committee citation said that Card was for his contributions to economic, while Angrist and Imbens were being bestowed the honor for their methodological contribution to the analysis of causal relationships. Why this year's prize matters. Modern economics has increasingly been struggling in reconciling textbook wisdom and the real world. The Nobel Committee made a big signal on this count in 2019 when it awarded the prize to Abhijit Banerjee, Esther Duflo, and Michael Kramer for popularizing the randomized controlled trials, RCTs, a technique usually deployed in medicine in answering economic questions. This year's prize in recognizing that natural experiments help answer important questions for society has underlined that RCTs need not be the end all and be all of economic methods. However, it also underlines the importance of rigor in arriving at conclusion. The science of economics, measurement of in economics has become so important that this year's Nobel Prize has gone again to scientific societal research in economics. And remember, MIT also has our own Amartya Sen teaching there. So the overall theme affects all occupational professionals for these Nobel Prize. One way or the other, it is related to medicine, society, refugees, migration, and the problem of labor economics. So it is the interconnected world. Once again, we underscore the importance of One Health at the center of human action and human survival. Thank you so much for patient listening, and I'm really grateful for the attention you've given.
Thank you, Dr. Rajiv Kumar Jain sir, for giving an elaborative presentation on the COVID rapid updates and the new developments which have taken place at various levels. Dr. Gajendra Kumar sir, you have some question?
Yes, certainly. I got certain observation and certain questions. So first of all, I compliment Dr. Rajiv Jain for a wonderful presentation. He has gone into detail of all the aspects of COVID update and as well as the environmental issues and the tuberculosis issue. Now, Dr. Jain, I got 3 questions with you. Number 1 question, don't you feel that the government of India and the expert group on the vaccination, they were in a haste to announce the vaccination for the children under 18 with the vaccine, though only the clinical phase 1 trial were over. Second trial phase 2 and phase 3 results are still awaited. With the result, many people, most of the person, they are all afraid of getting their children vaccinated. So your comment on this. This is number 1. Number 2, what I feel is that as Indians, we are very daring people. The moment the COVID fear of the COVID phobia is reduced, people have stopped wearing masks, or in case they are wearing masks, they are just hanging the mask on their chins, their nose exposed. With the result, practically they are not wearing masks. And as far as the tuberculosis is concerned, see, my observation is the least number of cases of tuberculosis are reported in Japan because persistently throughout the year, they are in a habit of proper wearing masks. So not only this, we are exposing ourselves to the COVID. I find so many people in our hospital without wearing proper masks. Even the tuberculosis, it will go a long way and there will be explosion of tuberculosis in coming days unless we start wearing masks properly. And I think it should be a regular feature for years to come. Why only during COVID era? It should be a regular feature because we are thickly populated area, thickly populated country. This is number 2. And my number 3 observation is regarding this environmental pollution. See, attending a conference in anywhere in the world is not going to help unless until we work at the ground level. What is the ground level in Delhi? I tell you about Delhi. Daily in the morning, when we move out of our homes, the municipal workers start grooming the roads and roadsides. And a cloud of dust there is. I don't call them safai workers. I call them dust raiser. Daily in the morning, the whole of the daily, they keep on raising the dust till 10 o'clock or 11 o'clock. I think we should stop it. This is one. And number 2, again, the same problem of burning of that parali in the northern belt of the country, and the pollution has started raising. So why we don't work on the ground level? I mean, it is better to work on the ground level instead of attending a conference in Geneva or elsewhere and discussing all useless things. These are my 3 questions. Your expert opinion and comments.
Thank you for raising these 3 important issues. The number 1 regarding ZyCoV-D vaccine. There are 2 phases for any vaccine authorization: the process subject expert committee, then NEDVAC, and the national committee, NTAGI. The 3 layers are there before Government of India takes a considered decision to implement that on the ground. The process, what happens when SEC makes a decision, the press publishes it. So that is not the way to actually presume that Government of India has authorized usage. Emergency user authorization is only a stage in the process of use of a vaccine. The process is still on. As you know, Niti Aayog member had already told, at the moment for ZyCoV-D, the applicator training is going on all over the country. And ZyCoV-D is for 12 to 18 years of age group. That's part 1. The second vaccine, which has received EUA, only the SEC has recommended. CDSCO will take a decision. Then NTAGI, NAGVAC also will consider, and standard operating procedures will be laid down, and production capacity and logistics of transport and cold chain shall also be ensured before it is launched as a part of the national immunization drive for COVID-19. So the process is on at the moment. The press reporting should not raise any high expectations, because in the first place, it is not essential to vaccinate all the children. That is number 1. And this is reiterated number of times by member Health Niti Aayog, who himself is a pediatrician and who understands the whole issue. So there is no hurry in introduction of vaccine for children, especially 2 to 10 years of age group. Also, the only children or young adults who would require this kind of vaccine is children with decreased immunity and having comorbid condition. The list of comorbid condition is still under preparation, and let us wait for the phase 1 rollout for a very restricted group of children, especially young adults of 10 to 12 to 16 years of age group. And then in the next phase, which will still sometime in future, the 2 to 18 years, special groups of children. It will not be for general immunization of entire population. In fact, in my presentation also, I made a point again. Now we come to tuberculosis issue. And there's no doubt that tuberculosis, due to the pandemic fear or whatever social distancing or use of mask, it may have been controlled. But remember, infection and immunity go hand in hand in tuberculosis. 25% of the world population is infected, and the highest percentage of persons infected with tuberculosis exist in India. So they are all potential patients of tuberculosis. Part 1 of the story. Second, the disruption in treatment of tuberculosis, the existing tuberculosis patients due to pandemic may have led to development of tuberculosis, drug-resistant tuberculosis in those patients whose treatment for tuberculosis was disrupted. In addition, in future, the diagnostic facilities which need to be strengthened, it will take time because of slow recovery from COVID-19 pandemic in the healthcare facilities and in the community on the ground. No, the which is used for COVID-19 diagnosis is the same equipment which is used for diagnosis of tuberculosis. CBNAT is the same machine which is used for diagnosis of tuberculosis. That machine has been utilized for diagnosis of COVID-19. So it has to be again repurposed for diagnosing tuberculosis. That was the primary use of all these machines in all the institutions prior to the pandemic.
Right.
So that's part two. Third part, regarding pollution, no doubt. In fact, everybody across the global chain of leaders and state leaders, including the Chief Minister of Delhi, the Lieutenant Governor, are seized of the matter of climate action. In fact, there has been no other issue which is important now. In the next 3 months, you will see Delhi shall only be talking about climate action on the ground. So the whole talk is for action on the ground. His whole talk is for action and funding for the action. In fact, if you see the US elections, climate was very high on the agenda of the winning candidate. The current US president has won on climate action. He has brought back the US into the global decision-making process for climate action. So unless the developed countries fund the developing countries, because developed countries will never have the money to take action on the ground for climate action, which has been caused due to the problem which has been created by developed countries. In fact, India has been demanding that funding and financing has to be given by developed countries because all the nuisance that has been created due to pollution has been caused by the developed countries. Because unless money comes, nothing will work. So the talk in Glasgow in November is only to see the finance mechanism and so that action on the ground happens, because the pollution at the moment is worsening in the south of the world, that is Asia, Africa, and South America. While the money is with Europe and American continent, that money has to get transferred in a systematic manner to developing countries, especially India. And that is why global cooperation and global decision making is urgently required, because it will impact health. And health, when we say health, it is one health. It is now not human health or animal health. It is now one health. One health means environment, health of human beings, and health of animals as well. All the organisms related to each other. That's why climate action talk have to occur, decisions have to occur, and then action has to occur on the ground. That is why you find chief minister to municipal councillor are now focused on climate action, because they know if they do not act, they are going to lose the getting re-elected. So very relevant question you raised. Thank you so much.
Thank you so much, Dr. Rajiv, for such a detailed explanation. Thank you very much. Right.
Yeah, last question from Dr. Diag. Then we'll conclude the session. You have to unmute yourself.
I would like to compliment AEHOD, sir, Dr. Gajendra Kumar, Dr. Rajiv Kumar Jain, Dr. Sandeep Sharma ji, and others. With this quote, Atmanirbhar, Occupation Health. IAOH is India's largest occupational compliance platform for labor healthcare, consolidating health across India. Our IAOH is Center of Excellence and diligently keeps the healthcare up to date with the latest technology. We occupational physicians are Indian at heart and global in competence. These are the words really is made by Delhi team and the leadership of you. Thank you very much, sir. Our occupational health is really Atmanirbhar occupation health. Definitely, you have done a wonderful thing with so much knowledge, so much this one. I think it is wonderful. Congratulations. Please keep it up. The day will come, everybody will appreciate these things. And a lot of YouTube messages are there. YouTube, this one is there. Thank you very much, Dr. Gajendra Kumar ji, Dr. Rajiv Kumar Jain, Dr. Sandeep Sharma, and other AUHOD team. Thank you, sir.
Thank you so much.
Thank you, Dr. Tyagara sir, for encouraging comments, and definitely we'll keep up the baton, and we have been doing it for last 1.5 years, and despite all odds, we had been conducting the sessions every Saturday at 6:30 p.m. And this was also a session in this series, and
in fact, Sandeep, it seems we are in fact beating the world in knowledge dissemination for the last now more than 1 year and 10 months. It seems like that. Because no other platform has been so sustained.
Yeah,
absolutely.
As India is celebrating Azadi Ka Amrit Mahotsav, 35 years of this freedom, now next episode will be 75th episode.
Yes.
And soon we'll be meeting every one of you with a new topic, new insight about the COVID and occupational health updates from Dr. Rajiv sir. So thank you all very much. Thanks all the panelists and all the viewers for attending the session and sparing your valuable time. Thank you very much.
Thank you so much. Thank you, everybody.
Good night, everyone.
Good night.